Dr. Namrata. At the onset, I thank AOS, Dr. Namrata, Dr. Mahipal, Dr. Gaurav for giving me a chance to be here with you. See, after seeing so powerful presentations of intraoperative OCT and cheese manipulations into the chamber, many a times you feel you really don't see anything on the cornea and you have to do a phacoemulsification, especially in centers like us where we do not have a cornea immediately available with us. We don't have a corneal surgeon immediately to help you. My thanks. This whole presentation is an inspiration from couple few presentations of Dr. Namrata, please. Well, uh, corneal opacification is a major cause of blindness in the developing and the developed world. Associated age-related cataracts contribute to the poor visual acuity. Suboptimal visualization of the lenticular morphology can render intraoperative difficulty. And these presentations present you many times on the table when you don't have a choice or you have not worked for them. Well, at the same moment, you got to take a decision for the surgery, whether we have to do a phacoemulsification alone or a combination of corneal transplantation plus cataract. Corneas are not available that fast. We don't have center like mentors, Dr. Amar Agarwal, who can do all the procedures at one stage. So we think what to do. Well, the deciding factors are evaluation of the grade and extent of the corneal opacity, the haze in the cornea, the expertise of the surgeon. He chooses whether he's going to do a small incision cataract surgery, an ECC or phaco, or a transplant plus cataract surgery. Availability of a donor cornea is a great problem. Visual requirement of the patient and the risk versus benefits takes us to deciding the surgery in hazy corneas. And of course, we do give patient a choice. Well, the grade of opacity, extent of opacity, anterior layers of the cornea, we do ALK and phaco, posterior layers of the cornea. When the corneal surgeon is in hand, DESEX and DMEC, all layers are involved, a triple procedure. Then, what is the location of the opacity? Whether it is paracentral, it is peripheral. Phacoemulsification alone can be possible. When it has a central corneal opacity, it may need an additional surgery of ALK and phaco. Well, surgical techniques are surely dependent on the placement of the corneal opacity and the eye you are operating upon. It can be a temporal incision and it can be a superior incision depending upon what part of clarity of the cornea you are facing under the microscope. And this all lets for a fraction of a moment for the surgeon to decide. IL power calculation is a problem itself. Optical biometry is mostly impossible. Axial length can be measured with ultrasonic methods. Other keratometry can be used for IL approximations. IOL should be a monofocal. Intraoperative requirements, a microscope with a good retroillumination, a must. Staining with trypan blue, dispersive viscoelastic, nylon hooks if the pupil is not dilating, and an endo-illuminator chandeliers light. Well, if we take out to this case, it's an opacity through which you can work. The only careful step here is getting a good raxis and a complete raxis in one step. Retroillumination gives the whole aid, whether you are doing a raxis or you are doing a hydrolamination procedures or you are continuing to phaco. A slow motion phaco with less power, and if you can elevate the whole nucleus. It becomes easy to emulsify it under a good viscoelastic in the anterior chamber, supracapsular, and in the iris plane. These cataracts are always nearly soft and they come out very easily with phacoaspiration itself, leaving a good cornea behind for the patient's useful vision. Well, many a times you are faced with corneas like this. Patient is not willing for a transplant, but he needs his cataract to be removed for reasons causing a little of secondary glaucoma, a little of visual rehabilitation. These are difficult to approach, but not impossible. Trypan blue staining, a good Raxis under a good viscoelastic. Of course, retroillumination is the sure and a good method to help. Visual clarity can be obtained by repeatedly putting viscoelastic on the cornea. It gives magnification, it gives a better view, a better transparency, of course not very good, but definitely better. And Rexes got to be completed in one go. That's one thing which you cannot miss. Again, these steps have to be carefully performed because the visualization is poor. You have to hydrate or hydrodeluminate the cataract, do a slow phacoemulsification, saving the corneal endothelium for a good residual vision via good viscoelastic, preferably repeated installation of the viscoelastic, which is a must. And finally, you are able to achieve something which is useful for you, your confidence, and a good vision for the patient. Of course, no denial that you need a transplant here, you need a triple procedure here, but limitations are innovations, and we want to complete a procedure, and the patient can then quietly wait for a transplant or to be referred to a good surgeon. Now, this is a challenging case where nothing is viewable, but patient needs has come for a phacoemulsification or a cataract surgery. And we have no choice except to use. See, this light gives you an excellent view of the cataract. The corneal opacity virtually fades away, and you can do a safe phacoemulsification. Again, a complete, large, and a good wing capsular access in one go is what is must, especially when you come under the corneal opacity. Hydrodelumination is a very important procedure. Though the phacoemulsification is difficult, but when done patiently is very easily possible, and then the patient can easily wait or for his further visual rehabilitation. The all steps of phacoemulsification have to be taken very carefully and very patiently. Things are quite different than a routine surgery. You just can't get hold of the nucleus, but little patience will definitely allow you. And this is called as a forward chop, holding the nucleus and cutting it from the back. Removing the last piece is equally well. Here, what we usually practice is do a one hand phaco, that is, once you have these pieces, remove your chopper and these pieces will safely come into the phaco handpiece. The whole procedure has to be patiently done and at a low parameters. Conclusion, well, these are the choices when you don't have everything at your center, but you need to choose the patient, explain to the patient, explain visual prognosis. A good microscope with retroillumination is a must. Surgical technique should be comfortable to the surgeon and patiently done. Thank you.